Hello everyone, I am Dr. Hani Diptiman and we will be continuing the topic of schizophrenia. And in the last lecture, we discussed about history of schizophrenia and the signs and symptoms of schizophrenia. So now we will be looking into the age and sex distribution of schizophrenia. In schizophrenia, the age distribution is between 20 to 24 years in the males, while in females it has two peaks. First is 20 to 24 years, and in the second peak it is between 34 to 36 years. So before the age of 30 years, the prevalence of schizophrenia is more common in males, while by after the age of 30 years, the prevalence is more common in females. So overall, the prevalence is equal in both males and females. Now we will see how the symptoms of schizophrenia progress. So first is prodromal phase. In this prodromal phase, there will be withdrawn behavior, and the patient will not talk much with other family members and relatives. Then there will be a active phase in which there will be delusion, hallucination, and other positive symptoms of schizophrenia. And then there will be a phase of residual symptoms in which the positive symptoms will vanish and only the residual negative symptoms will be there. And these negative symptoms are most resistant to go. Now we will be discussing about the neurobiology of schizophrenia. So first we will be discussing the genetics. In genetics, the schizophrenia is a polygenetic disorder. There are multiple genes which are affecting it, not a single gene. So there were various family studies done in which it was shown that a person has nearly a normal person from a non-schizophrenic background has a risk of 1% of developing schizophrenia in his or her lifetime. While if one of the first degree relative is a case of schizophrenia, the risk increases to 5 to 10%. If one of the parents is affected or is a case of schizophrenia, the risk is 10 to 20%, while if both the parents are affected, then the risk increases to nearly 40 to 50%. Next, there are also certain twin studies done. In twin study, we see the concordance rate. Like if one twin is affected, what are the chances that the other twin will also be affected? So in monozygotic twins, the risk is nearly 40 to 50%, while in dizygotic twins, the risk is 10 to 20%. And also there were certain adoption studies done in which the if the parent is having schizophrenia and the child already has a high risk of developing the disorder, so the child of that parent is taken and was adopted in a non-schizophrenic family, but still it carries a high risk. So this shows that schizophrenia is a genetic disorder and it has a bit of environmental effect, but the major chunk is due to the heritability, which is nearly 70 to 80%. Now we will see the type of genetic studies which were done in schizophrenia. So one was candidate gene studies in schizophrenia and the other was genome-wide association studies. So the candidate gene studies, in this 4 or 5 particular genes were studied, while in genome-wide association studies multiple genes were found out because the whole genome of the human body was studied. So first we will see the candidate gene studies. So the first gene we will be studying is DRD2, dopamine receptor type 2. So this is the target for D2 blockade drugs like typical antipsychotics. And in the mesolimbic area, there is dopamine axis, which is responsible for the positive symptoms in the schizophrenia, that is delusion and hallucination. And antipsychotics block this D2 blocker to D2 receptor to reduce the symptoms. Next gene we will see is COMT gene, catechol O-methyl transferase. So there is increase in the activity of catechol O-methyl transferase, which in turn reduces the dopamine levels since it metabolizes the dopamine. So there is two variant, val variant and mat variant. So when there is mat variant, which is protective for schizophrenia, while there is a val variant at the 158 location. So this is responsible for increase in the COMT activity, and so there is more breakdown of the dopamine in the prefrontal cortex. So when there is more breakdown, this results in cognitive decline and negative symptoms and impaired executive functions. Okay, so there are two variants, val variant and mat variant. Val variant is lethal, mat variant is protective. Next gene is disrupted in schizophrenia 1. So this is responsible for the axonal growth, synaptic formation and neuronal migration. Next gene is dystrobrevin binding protein, and this is mainly responsible for the synaptic function and the vesicle release. So if it is impaired, and which impairs the glutaminergic transmission and the synaptic dysfunction, which is again responsible for the cognitive deficits and the negative symptoms. There is another gene, neuroglin 1 and NRG1, which is responsible for myelination and synaptic plasticity. So like we can just summarize these genes. DRD2 is responsible for dopamine 2 receptor, COMT gene, dopamine metabolism in the prefrontal cortex, DISC gene, neurodevelopment, DTNBP1 gene, glutaminergic and synaptic function, and NRG1 for myelination. Now, in genome-wide association studies, apart from the genes which we found out in the candidate gene studies, some other genes were also found out, like glutamate, GRM3, GRIN2A, GRIA1. While certain calcium voltage gated calcium channel genes were also found out, like CSENA1C, CSENA1I, and CSENB2. Certain immune system genes were also found out, like complement C4. The complement C4, it helps in synaptic pruning. So in schizophrenia, there is excessive C4 activity, which increases the synaptic pruning mainly in the adolescent age. Now we will see the copy number variation. What a copy number variation? Either there is deletion of some of the genes, or there is duplication of some of the genes. So normally human have two copies, and most of them, one is from each parent. Now, example of the copy number variation we can see in the DiGeorge syndrome. We studied this MCQ in the NEET PG also. 22q11.2 deletion syndrome. In this, there is deletion of the long arm of the 22 number chromosome at 11.2 region. So there are certain type of symptoms in this, like you can remember that by the mnemonic catch-22: cardiac defects, abnormal faces, thymic hyperplasia, cleft palate, hypocalcemia, and it is present on the chromosome number 22, 11.2 location, long arm of chromosome number 22. And why we are studying this in psychiatry? It is due to the reason that 20 to 30% of these patients are have the risk of developing schizophrenia. There are also some other copy number variations, like 15q 13.3 and 16p 11.2. Now we will see the neuroanatomical changes seen in schizophrenia. So overall, there is reduction in the brain volume. Gray matter also there is reduction. Prefrontal cortex, temporal lobe is also comparatively reduced in size compared to a normal person. Brain symmetry, in the brain symmetry there is reduced frontal, temporal, and occipital lobe symmetry, and there are enlarged lateral and the third ventricles. Hippocampus, entorhinal cortex, thalamus, basal ganglia. Sorry, not basal ganglia. Hippocampus, entorhinal cortex, and thalamus. These all three are comparatively reduced in size. In basal ganglia, there is increased neuronal activity in the caudate and the putamen. So this is responsible for the abnormal movement that we see in the schizophrenia. In white matter, there is reduced myelin-related genes like myelin-associated glycoprotein, myelin and lymphocyte protein, and NRG1 disc. Synaptic density is increased due to the synaptic pruning. Now we will see the neurochemistry aspect of the schizophrenia. First, we will see the dopamine pathway. There are basically 4 dopamine pathways. The first we will study is mesocortical dopamine pathway from the ventral tegmental area to the prefrontal cortex. So this branches to the dorsolateral prefrontal cortex and ventromedial prefrontal cortex, which is responsible for emotion and affect, that is ventromedial prefrontal cortex, and dorsolateral prefrontal cortex is responsible for cognition and the So now we will be seeing the mesolimbic dopamine pathway. It is from the ventral tegmental area to the nucleus accumbens, and this is responsible for motivation, pleasure, and reward. Emotional behaviors, positive symptoms of schizophrenia like delusion and hallucination, and the deficient functioning causes the inadequate reward mechanisms. And there is higher incidence of the substance use in schizophrenia, especially the nicotine. Next is nigrostriatal dopamine pathway. It is from the substantia nigra to the basal ganglia or the striatum. There is hyperactivity of the dopamine, which causes the hyperkinetic movements like chorea, tics. And the chronic blockade of the D2 blockers will lead to neuroleptic induced tardive dyskinesia. There is a tubuloinfundibular pathway from hypothalamus to the anterior pituitary, and in the untreated schizophrenia, the function of the tubuloinfundibular pathway is surprisingly normal. Next we will study is the glutamate role in the schizophrenia. The NMDA hypofunction hypothesis is there. So the glutamate activity in the NMDA receptor is hypofunctional, which is responsible for the symptoms, and the ketamine and the phencyclidine are the NMDA blockers, which produces the schizophrenia-like psychosis. And next we will read about the GABA. In this, there is loss of GABA neurons in the hippocampus, and the GABA is has regulatory effect on the dopamine activity. The loss of the inhibitory GABA neurons leads to dopamine hyperactivity. In serotonin, we can see that there is serotonin excess, which is responsible for both positive and negative symptoms. So the drugs like clozapine, which is the second generation antipsychotics, reduces both positive symptoms also like delusion and hallucination, and also the negative symptoms like the withdrawn behavior. Acetylcholine, there is upregulation of the nicotine receptors seen in normal smokers, while contrary in the schizophrenic patient, there is decrease in the nicotinic receptors. Now we'll see the neuroimaging aspect in this. There are three findings which are very much common in the CT of the schizophrenia patient. The first most replicable finding is enlarged lateral ventricles. The second most replicated finding is there is medial temporal volume reduction. The third most replicated finding is ventricle enlargement. So the first most replicated finding is enlarged lateral ventricles, then medial temporal lobe volume reduction, and the third is ventricle enlargement. Certain MRI studies were also done, and which shows that the parietal lobe, occipital lobe, thalamus, and cerebellum, these all the four are reduced, and in basal ganglia there is decreased volume abnormality, while in 63% of the cases of the corpus callosum area also show the abnormalities. On diffuse tensor imaging, it shows that there is axonal density abnormalities, axon and myelin integrity disruption due to the disease, medications, and other environmental factors, and neuroinflammation with or predates psychosis onset. In the PET, SMECT, and functional MRI, it shows the reduced activation of the prefrontal cortex, which is also called as the hypofrontality, which is responsible for the cognitive deficits in the schizophrenia patients. Now we will see the neuroimmunology in these patients. So we can see that in the schizophrenia, the schizophrenia risk is increased after the influenza infection, autoimmune encephalitis, and higher infection rates in schizophrenia. So why do this occur? Because there is increase in interleukin 2, soluble form of interleukin 2 receptor, and interleukin 6 in the first episode psychosis. Also, there is elevated C-reactive protein, which correlates with the positive symptoms, and there is decreased T cell functioning, which is responsible for increased infection in these patients. So now I think we will be just going through the MCQs. So the most heritable dimension of schizophrenia is the disorganization symptoms. Which receptor abnormality is seen in schizophrenic smokers? There is decreased nicotinic receptors. Which dopamine pathway causes tardive dyskinesia when blocked? Which gene is linked to the synaptic tuning in the schizophrenia? It is C4. The hypofrontality, it refers to the reduced frontal blood flow, prefrontal blood flow. Which pathway is responsible for the positive symptoms? That is the mesolimbic pathway. And the phencyclidine and the ketamine produce schizophrenia-like symptoms by blocking the NMDA receptors. Which gene is associated with the myelin function? This is the NRG1, neuroglin 1, and the patient laughs and describes his mother's death. So this is an incongruent affect in which the mood and affect both are opposite to each other. Patient said that my thoughts are being removed by the aliens. This is thought withdrawal. So thank you everyone. This is for today, the neurobiology of the schizophrenia, and we will be continuing these lectures on schizophrenia and other important psychiatry topics in the subsequent videos. Thank you.